Hello, everyone. Have you ever wondered how a doctor's consultation style might influence a patient's satisfaction? Is it the way they explain, their tone, or perhaps their approach to decision making? These questions were at the heart of a fascinating study that was conducted by Savage and Armstrong in 1990. Now, this particular study happens to be a key study, and we come across this study while preparing ourselves for the first unit from health psychology, that is patient practitioner relationship. Moving on towards the title of the study over here reads Effect of a General Practitioner's Consulting Style on Patient Satisfaction. We're talking about how a doctor's or a practitioner's consultation style affects the satisfaction level of the patient. How satisfied does the patient feel according to or as per the consultation styles of the practitioner. Now, there are two very popular consultation styles that we speak about over here. The first one being a doctor centered consultation, and the other one being a patient centered consultation. Now, as the name suggests, when you talk about doctor centered consultation, this is led by the doctor, where the patient plays a very passive role during the conversation, during the consultation. The doctor's major focus revolves around the very first symptoms that are mentioned by the patient, and the doctor might end up disregarding newer symptoms that the patient might talk about at the latter part of the consultation. This might as well include closed questions where the doctor prompts very short replies and limits the discussion. Nothing extra is typically allowed during consultations of this sort. The atmosphere again might end up being very impersonal, and the concentration of the doctor over here is to provide a medical explanation for the symptoms that the patient is experiencing. On the other hand, if we speak about, or when we speak about patient centered consultation, as the name again suggests, is less controlled by the doctor, where the patient might play an active part in the consultation. The doctor, in contrast to how it was in the doctor-centered consultation, the doctor might end up using open questions over here. The patient might be encouraged to share information, how he or she thinks, how he or she feels. And of course, this would consequently lead to a very personal atmosphere, which where the doctor would again try to the best of his or her capacity to avoid medical jargons or technical medical terms that the patient might not be able to understand. The last thing that I'd want you all to keep in mind in a patient sector centered consultation, the patient might end up actively participating in the decision making process, which might as well include prescriptions too. So, back to square one, this study was conducted by Savage and Armstrong. In this study, Savage and Armstrong were trying to figure out the impact the consultation style of a practitioner has on the satisfaction level of the patient. There were two major consultation styles that we'd speak about here. The first one being the doctor centered consultation style, and the second one being the patient centered consultation style. Now, taking this ahead, if we speak about the background of this research. Now, like I said, this study was conducted in the year 1990. Prior to this research, there have been other researchers that I feel are important for us to bring in the discussion here. There's this study that was conducted by Caton and Kleinman in the year 1980, and the findings of this research show that a patient-centered consultation style led to a better understanding and more of adherence from the patients, right? So what I'm trying to explain you over here is, if we discuss the background of the study, we have studies that show us that patient-centered consultation are are considered to be better as compared to doctor-centered consultation styles. However, at the same time, we also have studies that show us that doctor-centered consultation styles have been preferred by patient as compared to patient-centered consultation styles. So, giving this a read, a study that was conducted by Caton and Kleinman in the year 1980. Some studies highlight the benefit of a sharing style, that is a patient centered consultation style, where the patient is involved in decisions, leading to better understanding and more likely following of advice. So, this study by Caton and Kleinman very clearly shows their support towards patient centered consultation style. However, if we talk about another study that was conducted by Ingelfinger in the year 1980 again, this shows that using a more directing style, that is a doctor centered style, with the doctor taking charge of the consultation, can reassure patients and make them feel better for effective medical care. So, the idea that I'm trying to float over here is both doctor centered consultation as well as patient centered consultation have their own support through different studies. Now, taking this further, if we have a look at the aim of the study. Having a look at the aim of the study, pretty simple. The aim of the research was to compare the effectiveness of directing and sharing consultation styles by a general practitioner on patient satisfaction with the consultation. So, how satisfied does the patient feel with the patient centered consultation style versus the doctor centered consultation style? Having a look at the research settings, this research was conducted by a general practitioner. So there was this one GP, one general practitioner, who conducted this research during the regular sessions, regular consultation sessions that he had. And this went for about 4 months. Talking about the selection of the patients were selected through a random number generator, which again adds to the credibility of the research. A random number generator was used to select 4 patients during each session. So there were 4 patients that were selected during each session. If we talk about the age eligibility criteria over here, patients age range between 16 to 75 years with any symptoms, right? However, there was an exclusion criteria as well. Patients who had any sort of life-threatening situation, life-threatening condition were excluded. There were some patients that were excluded because of administrative reasons or certain preventive measures too. Let's repeat. This study was conducted by a general practitioner. This study was conducted over a period of 4 months. There was this general practitioner who collected data during regular sessions, regular consultation sessions. There were 200 participants that completed the entire study, and linking this to the ethical guidelines for this particular study, there was written consent that was sought from those participants for audio recording. So the situation over here is 200 patients collected, or I'm sorry, 200 patients went or were a part of this particular study. And by the end of the study, they had to fill out a questionnaire right after the consultation and a week apart as well. Taking this further, if we talk about the style allocation, so what happened was, as soon as a patient walks in, initially the consultant or the general practitioner would greet them, and after greeting, the patient would describe his or her problems, whatever the symptoms are, and then the doctor would have two cards right in front of him, 2 cards that are faced down. There are 2 cards that are face down. A situation that we're talking about, let's just say if I'm the consultant over here, I have 2 cards in front of me that are faced down, right? So the patient walks in, the general practitioner would be expected to greet the patient, and then the patient would be expected to describe his or her problems or tell the doctor about his or her symptoms, right? Now, moving on, a set of cards created for random allocation. The random allocation over here was either the directing consultation, that is doctor centered consultation, or shared consultation, that is patient centered consultation. Cards had prompts for 5 main parts of the consultation. Now, these different cards that we're talking about, they had prompts for 5 main parts of the consultation. What are these 5 main parts of the consultation? The first one was judgment of the consultation. Number 2 had to do with diagnosis. Number 3, treatment. Number 4, prognosis. Number 5, follow up or closure. I'd want you all to have a look at this table. This would help you understand these prompts better. So a part of the consultation like this reads judgment on the consultation. If we talk about a directing consultation style, we pick up another color. If we, oh, that's even darker. So if we talk about the directing consultation style, an example of this could be, this is a serious problem. However, the sharing consultation style might be, why do you think this has happened now? Again, moving on to the second prompt over here, the diagnosis prompt. An example of directing consultation style could be, you're suffering from dash dash dash. However, the sharing consultation style example could be, what do you think is wrong? The third prompt over here would be about treatment. An example of directing consultation style over here would be, is it essential that you take this medication? I'm sorry, it is essential that you take this medication. Whereas an example of the sharing consultation over here would be, would you like a prescription? Number four, the prognosis of this, the prognosis prompt over here. An example of the directive style over here was, you should be better in this many days. An example of the sharing consultation was, what do these symptoms or problems mean to you? The fifth prompt over here was about the follow up and closure. An example of directing consultation style over here was, come and see me in this many days. However, an example of the sharing consultation style over here is, when would you like to come and see me again? Now, if you have a look at examples from the directing consultation style and sharing consultation style, you'd probably feel that the directive consultation style is actually better, right? I mean, that's at least what I feel after reading or going through this table. Going back to where we were, if we speak about the consultation process, cards were face down on the doctor's desk and turned over at the appropriate time. Initial greeting and patient's description of the problem preceded the card use. Patients completed a satisfaction questionnaire at the end of the consultation and another questionnaire after a week, right? After the week after the consultation, a week after the consultation, right? So a questionnaire, again, is an example of a self-report measure. So all the pros and cons of a self-report measure, all the pros and cons of a questionnaire should be kept in mind over here. How is it, or what sort of data was recorded over here? The time of consultation, the amount of time, the duration of the consultation, patient's demography, patient-related information, all of this was recorded. There were 200 patients who completed this study, right? There were 200 patients who completed the study. And remember, if you guys recall, right at the beginnings of the study, the patients gave a written consent. Patients gave a written consent about their audio being recorded, right? Now, an independent observer analyzed 40 random tape recordings. Out of the 200 recordings, there was an independent observer arranged by the researcher, and this independent observer analyzed 40 random tape recordings out of the 200 total tape recordings he had to ensure the effective execution of both styles. Now, effective execution of both styles. Remember, two styles. We're talking about two styles over here: the directive style and the sharing style, right? Where the directive style is the doctor-centered style, the sharing style is the patient-centered style, right? So there was this independent observer, and this independent observer went through 40 out of 200 random tape recordings to actually see if the doctor or the general practitioner had done what he was supposed to do the right way, or the independent observer was ensuring effective execution of both styles. And the result from this independent observer showed that there was correct identification of the intended style achieved in 39 out of 40 recordings. That's quite a lot. So the doctor was perhaps doing what he was supposed to be doing. The general practitioner was playing his role well. Now, taking this ahead, if we speak about the results of the study, remember, the duration of the consultation was being recorded as well. So if you have a look at the results here, there was no significant differences in the average length of consultations between directed and shared styles. Now, the general perception we hold is that a patient-centered consultation might end up taking more of time, But this did not stand out to be true, and it was seen that there was no significant difference found in the average length of consultation, be it directive consultation or even shared consultation. Moving on, if we speak about the general satisfaction levels of the patient, generally there were high satisfactions reported by patients. There were only three neutral or negative responses. So by and large, the patients were satisfied with the consultation. There were only three instances out of 200 where the patients either reported feeling neutral about it or had negative response. The crux of this research now, the final findings. If we talk about directing style impact, patients receiving directive style were more likely to feel that the doctor completely understood their problems. One, the first point in support of the directing style, which is also referred to as the doctor centered approach. Number two, patients felt that the explanation received was excellent, especially immediately post consultation and 1 week later, right? So both immediately after the consultation and even 1 week later. Although the ratings declined in the follow-up questionnaire after a week, they might as well have felt a little less satisfied, right? Nonetheless, but directing style had a better impact, had more of satisfaction level recorded. Number three, the third final finding over here. Those with directing style were more likely to feel greatly helped 1 week later if you compare that with the patient-centered approach, which was also referred to as sharing consultation style. These were the major findings of the research, right? Now, if we have a look at the factors that influence satisfaction levels, directing style was more effective for patients who rarely attended consultation, who had a physical problem, or were not investigated or received a prescription. So these were the factors that played a significant role in terms of satisfaction levels. Let me repeat that. Directing style was more effective for patients who either rarely attended a consultation or had a physical problem or were not investigated or received a prescription. One. Number two, there was no significant satisfaction difference for consultations longer than 9 minutes, those mainly treated with advice, chronic problems, or conditions perceived as psychological. Let's quickly conclude this before we hop on to the evaluative part. If we conclude this, directing style leads to higher satisfaction regarding perceived doctor's understanding, the quality of explanation, and subjective improvement 1 week later. So, the first word for directive consultation. Number two, contrary to the common view favoring shared styles, directing approach seems more effective for simple physical illnesses needing traditional biomedical approaches. Number three, for other issues like chronic or psychological illnesses, directing approach may not offer the same benefits, suggesting the need for further investigation. Now, I hope you've understood this study. Let's quickly move on towards the evaluative part. Remember, there were closed questions in the questionnaire. Where you have closed questions provide you with quantitative data, and this quantitative data helps you with comparisons and further helps you with analysis. It allows a clearer insight into patient satisfaction and their confidence level. However, since there were no open questions in the questionnaire, right? Since there were no open questionnaires in the questionnaire, you might or the researcher might have missed on the qualitative data, and because of which we can say that the findings of the research were were limited, or rather say the findings of the research did not provide a very detailed understanding behind the behind the satisfaction levels of the patients. One. Number two, generalizability. Remember, the sample was limited to patients from a single surgery over 4 months, the same general practitioner, which would, of course, reduce generalizability of the findings. However, the inclusion of both sexes and a range of ages offered some diversity. Remember, there were 200 patients. The age ranged from 16 to 75 years. The third evaluative point that we can bring in under discussion here, practical applications. The study revealed that a directing style led to a higher patient confidence and satisfaction. particularly for simple physical conditions, challenging the belief that a sharing style is always preferable. The general perception people hold about consultations is that patient-centered consultation, also referred to as sharing consultations, are better off as compared to directive consultations. So like this says, where did it go? So like this says, yeah, like this says, challenging the belief that a sharing style is always preferable. These findings provide valuable insights for improving doctor-patient interactions and tailoring consultation styles to meet patients' need effectively. Application of psychology to everyday life, or the usefulness of psychological researchers. You can always use this point as in an evaluative answer. Moving on, let's evaluate this research in terms of different types of validity and reliability. Now, as we speak about internal validity, the study's design ensured internal validity as patients were unaware that they were part of a study, reducing the risk of demand characteristics. If the risks of demand characteristics are reduced, this would automatically add on to the credibility of the study. This would add on to the validity of the study, internal validity. Additionally, the use of the same doctor and prompts for consultancy, sorry, additionally, the use of the same doctor and prompts for consistency controlled extraneous variables, ensuring the consultation style was the only variable affecting patient's response. Number two, ecological validity. The study achieved high ecological validity as consultations occurred in a natural setting, resembling real life interactions between doctor and patients. This makes the findings more applicable to everyday medical practice. So, the first type of validity, the second type of validity, the third type of validity that we can discuss over here is temporal validity. What again is temporal validity here? The use of questionnaires immediately after the consultation and 1 week later enhanced temporal validity by assessing how a patient's view change over time, providing a dynamic perspective on satisfaction and confidence. Moving on, we can also evaluate this research in terms of reliability. This study demonstrated strong reliability due to its standardization. Remember, there was a standardized procedure used. It was the same general practitioner who just had cards in front of him and he kept on flipping cards, and based on what the card read, he used the 5 different prompts to for his consultation. So the same doctor conducted all consultations, and the use of prompts ensured consistent application of the consultation style. This procedural consistency allowed for the replication of the study and confidence in the reliability of the results. So as we all know, if the more controls you have, the better standardized your study would be. The better standardized your study would be, the easier it would be for you to be able to replicate the research. Not only would it be easy for you to replicate the research, but at the same time, this would increase the chances of reliability. Reliability of that particular research can be high. Now, I hope this has helped you. Take good care of yourselves. Stay happy, healthy, safe, and protected. Stay humble, spread positivity, spread smiles, and Allah Hafiz.